3, 2, 1.
Good evening. Thank you for joining us in what is in our series, the third, Diaspora Mental Health Dialogues. We are so thankful for you joining us tonight. The Diaspora Mental Health for Equity Dialogues, this is number 3. And for those of you that are on our Facebook Live communication, and also those that are on the Zoom call, we are thankful that you took time out of your busy schedule for joining us tonight. Our panelists today are Dr. Renata Nero and Dr. Janice Beal, two very experienced professional counselors involved in the field of therapeutic treatment. We're most appreciative for you coming to speak to us this evening. Let us have an opening prayer. Lord God, we thank you for this opportunity once again to have a discussion and a dialogue about mental illness and how it affects our community as a whole here in Houston. And God, we ask that you touch each person that is involved tonight, allow them to listen attentively, but also gain insight and information from those who have been in this field for several years. And then may we be able to direct them and equip them with the resources to get the help that they need. We ask these things in your son, Jesus' name. Amen.
Amen.
This event is sponsored by the Baygood Foundation through NAMI Greater Houston. My name is Preston Allen, and I'm serving as your moderator. Today, the goal of this project is to increase the level of awareness, access, equity, and utilization for mental health resources within Houston, primarily in the Latinx and African American communities. We want to give special mention to NAMI Greater Houston, the team led by Dr. Neil Sarahan, Angelina Hudson, Jessica McDaniel, Asta Sharma, and Aditi Chokti. Just before, let me go ahead and introduce the speakers, and then after the speakers, I introduce the speakers with a brief background. We will have a commercial piece that will basically give a synopsis of someone who has experienced mental illness. Dr. Renata Nero, PhD, is professor of psychology and Sharon K. Burroughs Professor at Houston Baptist University. In addition, her teaching responsibilities, she is a licensed clinical psychologist in private practice and the chair of the executive board for the Ashley J. Dean Foundation, AJF. AJF is a suicide awareness and prevention organization that educates communities about the importance of mental health and supporting young people who are at risk for suicide. Dr. Nero is a former president of the Southwest Region, a board of directors for the Christian Association for Psychological Studies, and a member of the Texas Psychological Association. Our other guest panelist is Dr. Janice M. Beal. She received both a Doctorate of Education degree in Guidance and Counseling, Psychology, and Masters of Arts degree in Clinical Psychology from Texas Southern University. She earned a Bachelor's of Arts degree in Psychology from University of St. Thomas. She pursued postdoctoral education from the University of Texas School of Public Health and California School of Professional Psychology. Her leadership and administrative experiences include coordinator of the psychology program at Prairie View A&M for 7 years. She also was an assistant professor teaching classes in general psychology, research methods, and adolescent psychology, and on African American issues in psychology. Dr. Beal leads an organization called Beal Counseling Associates, where she's a clinical director and primary therapist. Her administrative duties include overseeing the billing and reporting processes for operations. She oversees the systems for each contract to ensure compliance with each client's reporting. She is an author and has written therapeutic coloring books for children. Thank you, Dr. Beal and Dr. Nero, for joining us today.
Welcome so much. Thank
Now
you.
we will, thank you. Now we will have a piece.
So my brother is one of those people who does not accept a diagnosis and will never accept one. And it can be disheartening, but it's okay, because that does not mean that we can't, as a family, help him. My name is Jacoby. I have a brother who was experiencing hallucinations. He was experiencing like very long banter, this kind of like harried identity of needing to help people, kind of like this euphoric type of feeling, and coupled with like very massive just bouts of being low. We just knew that he didn't seem himself for quite some time, and it was starting to put him at danger. And so I tried to kind of reason with him, like, yo, have you been feeling okay? He's like, yeah, I'm feeling fine, you know? And it was like you couldn't really have a lucid conversation. And he didn't really do well with any type of disagreement at all. So my mom found out about NAMI from a friend who was thinking maybe my brother was showing symptoms of something that was mental health related. For us, the pivotal class was the problem solving, because we saw problems totally different. You know, like my mom, the way she addressed it and the way I addressed it. From that problem solving point of view, we were able to really combine forces, even though we had differences in opinions of how he should be handled at the time. The best parts of the class, honestly, for me, I really loved the structure of it. I think that it was helpful to kind of have each week you go through a particular part of like brain chemistry or problem solving, and then you have a small moment to talk about your issues. And so each class kind of gave us a sense of purpose, a sense of direction, a way to feel like, okay, I'm understanding this thing a little bit more. My brother's involvement with NAMI had never really been straight on, because he never accepted that he had any kind of issue or diagnosis. And that's actually kind of quite common as well. And so I stopped pushing it, honestly. I stopped pushing the diagnosis, but I did ask him to get involved with me on a level of like peer support. But I think my brother's experience with NAMI was more so just feeling the result. So oftentimes in communities of color, we don't do the long labels and prognosis and those types of things. That's just not, it's not really our language. With my brother in particular, I noticed that we had that same communal issue, right? And it doesn't mean that he can't make changes in his life. It just means that we have to address it in a way that's more wholesome and that speaks to us culturally. My hope for tomorrow is that people are open and a bit more vulnerable to accepting help, because it definitely is out there.
Thank you.
Get a real-time bird's eye view of your projects. Create.
Thank you for that, brief synopsis of what is happening within the field. Doctors Nero and Dr. Beal, in your introduction, your bio, you're both leading therapeutic practitioners, and you also serve in academia. And given your experience in both fields, can you share with us a brief narrative that explains the development of psychology over the past, let's say, 2 decades? And I'll follow up with what encourages you about the field today and what discourages you today.
I'll let Dr. Nero go first.
Okay, certainly. I'd be happy to go first. Thank you so much for that question. And there are certainly several things that I have taken a special note of over the last few decades. And one of those things is the emphasis on evidence-based treatment and practices. the importance of being able to show increased quality of treatment when it comes to mental illness, and to also make sure that therapists have increased accountability. And with that being said, I am extremely pleased with one of the developments that has taken place within, let's say, even the past 5 years, that to make sure that there is increased accountability for therapists, we are now required to have 20 hours of professional development before being able to renew our license instead of 12 hours. I am also especially pleased with the emphasis on receiving training in the area of cultural diversity. There's more of a recognition that we are not the same, and that it's important to be able to understand ways in which we're different in order for us to receive the best possible care. The other thing that I am pleased to see when it comes to the development, some developments in psychology, is that for those persons that find that their faith is an integral part of their healing, there are now programs that are accredited by the American Psychological Association that allows for people to learn how to integrate their faith with the practice of psychology. These programs are accredited, and there are practitioners who know how to incorporate Christian integration when it comes to the treatment of mental illness. So those are just several of some of the developments that I've seen over the past decades that really apply to what it is I do as a clinician and what it is I try to do as an academician when it comes to training future clinicians.
Dr. Beal?
Okay. I totally agree with Dr. Nero. Throughout the decades, I think initially from the training that I had when I was in school, being more culturally sensitive and aware of the differences among the cultures has been in the forefront, as opposed to where it was the types of psychology studies that we did. So actually taking African-American courses or teaching African-American courses in psychology and other cultures diversity trainings, I think is one of the key things that I have seen throughout this time period. Cognitive-based therapy techniques, how that applies to all areas, not only mental health, but substance abuse, and being able to change the way people actually do therapy or go through the therapeutic process. And yes, being able to have an outcome base where we can determine whether or not a person has gone from one stage to the next. So people would ask what was the best approach that I'd like to use, and I always use the term eclectic approach, because I would think that I was pulling from all the other theorists that I had learned throughout the years, but being able to teach and help people to, and I always say to get whatever works best with an individual is what I try to do. So sometimes it may have steered just a little bit from what was actually, it could have thrown Freudian, Jung, we could have thrown all those people in together in order to be able to reach people and for change to happen. I think we can measure change a lot better now than we probably were when I got, I'm almost at 30 years. I can't believe that. I'm not going to say that. I'm going to back out and say, let's just say I started when I was very young. But yes, I've really seen a change in the field. I've seen more people wanting to be a part of the field in order to be able to help. The ability to have different disciplines come throughout the time. You know, from an Afrocentric approach all the way to any other types of approaches that we've been able to do. So there has been a change. And I guess it's a welcome change, because as people learn more, then we're able to do better. Would probably be the best. And your second question was? What
discourages you? What discourages you?
Well, the fact that even though we've made a lot of monumental leaps, I think, in the field, people of color are still underserved. Our numbers, as I look back on when I was doing research, when I was teaching, I haven't taught for several years, but the numbers have not changed as far as access to health care. The stigma that still exists, I think for some of the writings I've said, I'm a drum major for mental illness because of the fact that the stigma is still there and we're still talking about reducing the stigma of mental health. You'll meet people that think that they cannot, if they don't want to be crazy, or the lack of terms, what happens in our house stays in our house, or we don't share with the information. And that's like generational. It's kind of like we can't stop that stigma from being repeated from generation to generation. So education, yes, has improved, but it's a little discouraging as you look at how we access healthcare. Most of the people who are not connected with a therapist access to the emergency room still. As far as we're finding our jail systems that are responsible for treating a large number of people with mental illness. So the movement is moving, but it's just not moving fast enough for me.
Thank you. Dr. Nero, do you have anything on the discouraging side?
Yes, I do. In fact, I do want to say just a couple of more things that I do find encouraging, and then move into some things that I do find discouraging. And what I will say is I will go ahead and claim that I've been doing this for 30 years. I started doing private practice work back in 1990. And at that time, when I was integrating my faith with the practice of psychotherapy, there was less acceptance of that then than there is now. And so I'm pleased to say that it is easier for psychologists to actually collaborate with members of the clergy, and members of the clergy are far more likely to consult with psychologists and recommend their parishioners for psychotherapy. That is extremely important because for some communities of color, if the pastor co-signs on them seeking psychological services, then you're far more likely to have someone to actually be very motivated to stay in therapy. The other thing that I'm also encouraged by is that more and more celebrities are open about their experience with mental illness, and that really speaks to what Dr. Beal was saying about the stigma. And that as these celebrities talk openly about their treatment and encourage their followers to do the same, that tends to kind of decrease some of the stigma associated with mental illness. And the other thing that I'm seeing now that I didn't see, let's say 30 years ago, is an intentional change in the language that's used to talk about mental illness. So for example, my colleagues who are in the field of suicidology are very intentional about decriminalizing the language used when talking about suicide. So instead of saying committing suicide, they are very intentional about people using the term death by suicide or someone died by suicide. And the other thing that kind of speaks to some of the things we'll talk about tonight is the use of technology. And what technology does, it actually increases the accessibility for those who actually have the technology to participate in their own care. And this is especially important during the time of a pandemic. We actually have 3 pandemics converging at the same time. There is, of course, the COVID-19 pandemic, there is a social justice pandemic, and there's an economic pandemic. And the times are very uncertain, and to know that people can still receive care even during a pandemic via telehealth, I think that that's very important. And then speaking to the social justice pandemic, with the social justice pandemic, this really speaks to the role that mental health professionals are now sort of being asked to take on to really do our clients a service. And that is that in addition to being a therapist, it's important for us to be an advocate as well. That there's some things that we do outside of the therapy session to make sure that we promote mental wellness. In terms of some things that are discouraging, again, there's still the taboo, there's still the stigma associated with mental illness. Unfortunately, that continues to exist. And the other thing is, when I first got to Texas over 30 years ago, Texas was ranked like 48th or 49th I think that was when it came to mental health funding or spending. And right now it stands at 49th when it comes to accessibility to mental health care. So I find that to be discouraging when it comes to the field. And the other thing that I find encouraging and discouraging is the use of technology. That when it comes to technology, it must be used responsibly. if we are going to see the kinds of improvements in mental health delivery that we want to see. And in the age of social media, technology can be used to cyberbully, technology can be used to post very hurtful things, and technology unfortunately can be used to even increase some incidences we see in depression and anxiety.
Thank you to both of you for those responses, and thank you for being able to clarify what's going on. So we really have a double bang in each of you in the sense of a bonus because of your academic background and research, and also you being a clinical therapist in the field. So we're really getting a milestone, hit a milestone with your level of expertise. Thank you so much. If your streaming audience has questions, please send them now and we'll try to respond to them with responses from our panelists. Also, if you would like to reach out to gain help, or you know of someone experiencing challenges in unwellness into crisis, those are the levels. Emerging unwellness, unwell, and in crisis, please call the NAMI Greater Houston C Center warm line at 713-970-4483. That's 713-970-4483. Someone is standing by to try to listen to you attentively and address those issues. Also, just before we get to the next question, we have experienced a loss in the family, a young man by the name of Courtney Provo, and certainly we want to send out prayers and condolences to that family and our support to them in this difficult time. Our second question, Dr. Beal and Dr. Nero, please describe to us the demographic nature of your patient populations, and how do you address you already addressed part of this question before in the underutilization within the Latinx and African American communities?
Okay, well, my patients vary in age. I specialize in children and adolescents. So I do a lot of work in that area. And of course, with working with children and adolescents, you have to also work with families. Within the past, probably the past 10 to 12 years, I've opened 3 inpatient psychiatric units at freestanding psych hospitals. So I've seen an increase as far as the numbers of kids that we've admitted and the types of illnesses and what we're actually diagnosing. If we were to look for the tenure of my time, in some diagnoses we were not using with children and adolescents, but now we are. And we can see things a lot earlier, and we're able to diagnose things earlier than we probably were in the past, because we wanted to wait for time periods and things to change. For example, just a simple diagnosis of attention deficit disorder with hyperactivity. At one point, back in the day, we thought it disappeared by the time a person turned 18. But as time and research continued throughout that time period, we realized that it goes beyond that and it goes into adulthood as the new research started to come out. I've also had an opportunity to see what drug usage by parents have had an impact on children and adolescents. At one point, we didn't have enough research 30 years ago. I'll go ahead and claim the number. Dr. Nero, I'll claim the number with you as well. So the times have changed, and the information of what we did not know, or at least what I did not know in the very beginning of my practice, I now am able to see and to be able to diagnose more freely. For example, even autism. We've seen a massive increase in those who've been diagnosed with autism, whereas back in the day, whatever years we want to go back to, the diagnosis was not as freely utilized because people were not very well able to we knew it was there. We knew the DSM, we knew what it was, how to get to the diagnosis, but we have far more children who are being diagnosed with autism than they were in the past. So I think the increase with knowledge, the increase with research, and the ability to be able to understand people and human behavior has also made a difference. So I have that part of my practice with children and adolescents. I've had a program, on the other hand, drug and alcohol abuse and mental health for the federal probation system. So I've been a part of the juvenile justice system. I've been a part of the probation psychiatric hospitals. I think I've worked probably at all aspects of mental health that you could possibly think of, from school districts to coming in and helping when there was a crisis. So with that population of the federal probation, I've had for 20 years. We do mental health counseling and we do substance abuse counseling as well. So I don't really do all of that myself anymore, but actually that's a part of what I've done or what we do currently. So with children and adolescents, those are my babies. I can, I just love kids and I love being a part of their development and helping them and helping parents understand mental health. And so I think, Dr. Nero, thank you for using the term mental wellness, because we have changed the term. We're trying to make it where it's more acceptable. So I'll use the term mental wellness, and people are a little bit more accepting of that. So it gets me into the back door to be able to help parents understand. Throughout the years, I found that most parents feel guilty about their children having mental illness or having a mental health diagnosis. And so therefore, that's why they're less susceptible to actually seeking treatment. So it's all about how it's presented and helping them to be able to help me help you to help your child. And that's pretty much the approach that I use. So, and that adolescent population, I love that defiancy that comes along with everything as well. So they used to have names for me, but that's pretty much what my practice looks like. So it mirrors those different groups.
What is the ethnicity breakdown in your practice?
If I were to do an ethnic breakdown, I would say probably 80% African American. The other percentages would be pretty much even as far as Hispanic and Caucasian. So throughout the years, I've spent a lot of time with low income socioeconomic areas where I've gone in and volunteered and did work as well. So pretty much the breakdown throughout, sometimes it would go up, sometimes it would be at 90%, but at this point, I think it would probably be 80%. I'm looking at my assistant at the corner of my eye to determine whether or not that's pretty much where I've kind of had my, the referrals, but the referrals come from everyone. So it's not like I get someone, unless they're looking for an African-American female, would be the reason why they would probably, quote unquote, seek services. If not, whoever walks in the door, we're able to actually service.
Thank you.
Mm-hmm.
Dr. Nero?
Certainly. I wanted to first address the issue about underutilization with the Latinx and African American communities. And when it comes to underutilization, I see it as a two-pronged issue, in the sense that underutilization does deal with access. In other words, what is a person's access to receiving mental health care? But then the other issue has to do with what happens once you have the person in the therapy room. Once they've actually come in, are we providing them with the quality of care? Are we providing them with the level of cultural sensitivity and respect that is likely to keep them in therapy? At the end of the day, the therapy relationship is just that, a relationship. And it is important for clinicians to be aware of those things that can lead to relationship rupture. And so in that regard, it is important that once members of underserved communities are actually in therapy, they've actually accessed the care, they're actually in therapy, it is important for me to make sure that I understand their worldview, that I understand what their expectations are for therapy. It's also important to make sure that they understand the informed consent and the limitations of confidentiality. And it is important for me to make sure that I am someone who is deserving of that client's trust, and that I am seen as someone who is credible. The other thing that is important is to understand that for some underserved populations, there can be a history of cultural mistrust. And so in some cases, being viewed as trustworthy, having credibility, that actually trumps being an expert, even though it's very important to make sure that we are very, very well prepared, that we are trained. All those things are certainly very important, but sometimes trustworthiness and credibility to persons who may be coming in with a history of not feeling as if they can trust healthcare professionals is important, that we are clinicians who are certainly trustworthy, credible, and deserving of being able to work with that population. The other thing that,
no, go ahead, please.
The other thing that I'm sensitive to is that I'm sensitive to a person's immigrant status, especially if that person is undocumented. And so for persons who are undocumented, there can also be a fear that they will be reported to the authorities. And so again, helping clients to understand what is meant by confidentiality, and to understand that it is not the role of psychotherapy to turn over someone to the authorities based upon their immigrant status. So those are some things that I am sensitive about. Now, in terms of the demographic nature of my client population, I work with adults only. I only work with adults, and I work with persons between the ages of 21 to 80. And within that population, I would say probably at least 40% of my client population would be Caucasian, and maybe close to 30% would be African American, and then maybe 10% Asian, and moving towards and maybe 10% Latina, or Latina in particular. So that is pretty much my client breakdown. And in addition to working with clients in the therapy session itself, I also believe in community activism. That is very important to me, working within the community. And in the community, I participate in Zoom discussions such as this. My church recently had a mental health moment where I participated in that. I also do trainings. I also consult with schools, and I do staff development. And so those are ways in which I try to make sure that persons who work with individuals throughout the community are trained in dealing with issues surrounding diversity.
Thank you. I have two questions that I want to interject to both of you. One to Dr. Nero, and one to Dr. Beal. So the first one I'll shoot to Dr. Beal. I've heard, the question is, I've heard the stigma is really just discrimination. Do you agree? And then let me ask Dr. Nero the second question. As a person of color, I'm seeing a counselor who is also of color. How can I go about doing this? Or is there a database out there where I can find mental health counselors of color in my area?
Okay, let me make sure I'm gonna rephrase the question. The stigma is associated or synonymous with discrimination. Is that the question?
I've heard that stigma is really just discrimination. Do you agree?
I don't know if I would fully agree, because when we discriminate, well, that's okay. It depends on what aspect we're gonna take it from. I just thought about something that just passed. Because access to care may be a socioeconomic problem because of not having the ability to pay for services. I think initially it was stated where we stand as far as how much money is put into mental health care in our state. And if you look at the numbers, person of colors may have less access to health care. So that is discriminatory in one aspect. The stigma that I think was referred to when we go back to where did the stigma first start? And I guess I always, when I'm talking, a lot of times talk about the Tuskegee study that really starts with the fact that we were used, I'm using the term as a group of people, African Americans, who were utilized in a study without giving informed consent. And so when you are trying to understand why people have a disbelief in the system and why they disbelieve and they blame others because of the fact they can go back to that study or go back to other things where they feel as though the system is not for them. So, which means that would be a form of discrimination, thinking that, you know, no one wants them to be, or wants one to become well. No one wants everybody to actually be a part or to actually have whole wellness. So discrimination, yes, because I think that it was not, the system may not have really been put in place to state that we would be able to have healthcare. But we also, I see where the fact that the word of mouth, where not to trust people and not to trust anybody. So that's where the stigma originates from. So we have generations, well, I have generations of patients who've come in, from children to having children, and talking about once they realize that somebody's actually there for them. And once I say, if you look into my eyes, if I'm meeting someone for the very first time, if you can't see that what I'm doing is in order to be able to help you, then probably we're not in the right place. So when people feel as though they can trust somebody, then they're more open to actually seeking help and to being able to have someone help them from one aspect, or open up and share information. Also got to talk about trauma. Historically, a generation of people who have been traumatized. And I think our trauma has not actually been dealt with throughout the generations, going back to slavery, getting to the Tuskegee study, and then going forward to where we are today, because we've been constantly over-traumatized and not really healing from the different types of trauma. So when you're looking at discrimination, from being in this country, things that have happened as a result of that, and whether or not that builds mistrust, yes. So I guess I've actually answered it. I started off with a no, and then I've ended up with a yes, because as I'm thinking about all the things that have happened and how we've gotten to where we are, as far as how the stigma has continued to be perpetuated within the community, not only African Americans, but Latino communities as well, as far as not trusting others and not trusting the system. Yes, and the fear, because a lot of times with mental illness, it's fear. People are afraid, and fear generates a lot of things, especially with the pandemic that we're experiencing right now. The most major thing that I hear is the fact that everybody's afraid, and it's producing anxiety, and they're traumatized, you know, from Katrina to, I mean, I just have a whole list of things that I think that have added on to, and then also added on to the stigma of actually seeking help. But once someone testifies and states that how much and how therapy will work, it kind of, if they pass that information on, it helps others to be more open as far as seeking help, especially children and families and parents.
Thank you. Dr. Nero?
Yes.
You need me to restate the question?
Yes, please. Thank you.
Let's go back. As a person of color, I'm seeking a counselor of color. How can I go about this? Was that the one? Yeah, I think that was the one. And how can I go about doing this? Or is there a database out there where I can find mental health counselors of color in my area?
Okay, yes, so there are a couple of things, and I'll provide you with an example. So here in Houston, we have an organization called the Association of Black Psychologists. And so that could be an organization to contact if this is an African-American in search of another African-American with whom to do therapy. And there is something to be said about the matching of certain characteristics. There is something to be said about that, and whether or not a person may feel as if they're understood. And sometimes the assumption is that there will be a shared worldview, and that there may be some things the person may not need to explain about themselves if they are working with someone within their cultural group. So for some people, that is something that is attractive to them. And here is a caution. The caution is that people may be of the same race, ethnic background, they may share those things, but it does not mean that they are at the same level of development when it comes to their racial and cultural identity. And I'm going to use an example from the 1990s. Okay, so I'm not going to go too far back. Does anyone remember the television show, The Fresh Prince of Bel-Air?
Yes.
All right. In that particular television show, there were a couple of characters. There was Will and there was Carlton. Will and Carlton shared the same racial background, same ethnicity. They shared kinship. They were of the same blood, but they were very different when it came to their racial, cultural identity development. And let's say there's an instance where they were not related, they never knew each other. Will decides to go into therapy, and he ends up with a therapist like Carlton. There's a good possibility that they would not have a lot in common, and it may actually be a very frustrating encounter for someone like Will, because they do not share the same kind of racial cultural identity development. And that sometimes happens where the client could be at a different stage from the therapist, and it can make for a therapy that ends up being very, very dissatisfying, and the person ends up dropping out. And so again, sometimes the traits that are most important may not have to do with race or even culture. The trustworthiness, the credibility, those are the things that are very, very important in people being able to connect and be in relationship. But to answer the question, there are some minority mental health professional organizations where people can seek out a therapist who may share the same racial, cultural, ethnic background as they do. And then the other place I would direct someone to would be Psychology Today. With Psychology Today, you can actually see the pictures of the different therapists. You can see their pictures. You can look at their background. You can look at their experience. You can look at what they tend to specialize in. And that way you can make a decision as to whether or not you believe this person is a good match for you.
Thank you so much. The next question that I have is, you were discussing celebrities with mental health issues earlier. What are your thoughts on the current situation with Kanye West and his bipolar disorder? And will this be positive for the mental health community in the end? Either one of you can address that.
Well, I think what we saw that happened in Kanye West, currently, I guess I've seen some very cruel things that were said across social media with those who really don't understand mental illness. I think that once it is explained, and he has not been the only, I think, celebrity who's come out, and once he's on the other side of being able to, I guess, have his disorder to where he's able to function like he was previously functioning, then it'll be a learning experience. I would hope that they would utilize that as, him to be able to be on a platform where he'll be able to help others who may or may not have taken medication, or who may not have had a diagnosis or have actually gone to the doctor. Because you saw it unravel. And I started to watch all the things that were coming across, and people really were not, I think there have been talk shows talking about it, but to have to understand what mental illness is and what can be done in order to help him, not only him, but anyone else who may be diagnosed with bipolar disorder is very important. So I hope that we utilize that as a media platform in order to be able to become more aware when he's able to be able. I think his wife has come out and talked about it a little bit today, because I think I just saw one clip of what had transpired. Also, when we have celebrities who may have taken their lives, during that time period is a very good educational point, because therefore we can tell people when you're feeling a certain way, what you can do and the types of help that's available. I heard you talk about the warm line that's open right now. Hopefully that's encouraging to people that NAMI is sponsoring right now to be able to call. Hopefully we've sparked something where they're maybe thinking, well, maybe I do need help, or maybe I just want to have somebody to talk to. So from a celebrity standpoint, I think it's and there's another person, I think one of the Tamar Braxton recently, within the last couple of days, also was someone who was attempting to take her life. And so the awareness of the public, and I've seen money, like Beyonce has put money into mental health and mental wellness. So when people are talking about it and saying it's okay, from a perspective of those who people idolize, I think it's very, very important. So ultimately that would be a very good educational time for people to actually know that it's real, and we can seek help, and you can become better.
Thank you so much. And by the way, the Be Good Foundation, Beyonce's foundation, is a sponsor of this particular activity. And so this work is an outgrowth of that foundational funding, along with through NAMI Greater Houston and Jack Draper, who owns Twitter, a great amount of Twitter stock. The thing that I want to do is I want to mention the warm line to our audience, 713-970-4483, 713-970-4483. That's the NAMI Greater Houston C Center warm line. Please put that in a location, maybe on your refrigerator or near something that's of importance, and so that you can have quick reference to it. We'll probably come up with some idea. Maybe we can have little cards that can go in your wallet that might have that information on them as well. And let's go on to the next question. I know as a veteran living with mental illness, if you do not have a healthy relationship with the therapist or psychiatrist, my care, he's speaking of himself, my care and motivation go back to a decreased level. Go back to a decreased level. Dr. Nero, you want to take that one?
Sure, I'd be more than happy to take that one. And that one actually kind of speaks to something called relationship rupture, or the therapeutic relationship rupture that can occur in therapy. And there are times when a therapist, for whatever reason, has sort of lost his or her credibility with the client. And the rupture occurs when it's not talked about, or when it's not discussed, or if the client fears that he or she cannot can engage in this kind of discussion, that even in therapy, even though, we would hope that it's not that way, but in therapy, there is sort of a one-up, one-down relationship, and the client may see the therapist as being in a position that is of higher status within that relationship than the client. And sometimes the client may not feel at liberty to address issues of rupture. And it's important for the therapist to create a safe environment and to even check in with the client from time to time and talk about the quality of their relationship, or open up the floor for them to discuss the quality of the relationship, and if they feel as if something has changed or if something needs to be addressed. And when that happens, it's important for the, for that client to take advantage of that situation. And I do want to address something that can happen in a therapy session between client and therapist, and that is a microaggression. That means that something can be said, and it might be unintentional from the client's or from the therapist's perspective. It might even seem harmless, but there can be an exchange that is actually kind of wounding and offensive, that the client may feel as if they say something about it, they come across as being overly sensitive, or that the therapist might actually label them as overly sensitive. But if this issue is not addressed, the therapy is not likely to move forward. And research has shown that persons of color are far more likely to leave therapy prematurely than other groups. And so if someone is not feeling comfortable with their therapist, or if the trustworthiness and the credibility is going down, it's important to address that and to let the therapist at least have a shot at being a party to repairing the relationship.
Thank you. I have another question. I'm a junior high school nurse, and I'm interested in incorporating best practices of mental health resources and support in my role as a nurse. I find that a large majority of my students and their families are extremely emotionally dysregulated, and our school counselors, let alone teachers and administrators, are very limited in their knowledge or understanding of how to recognize and address this. I am not interested in reinventing the wheel. If there are programs in place to educate our school staff and support our educators and students, any thoughts? Let me just put a plug in here. That's one great opportunity for NAMI Greater Houston. There are numerous programs throughout the city. The program director, Angelina Hudson, who's on this call, is one of those persons. So I would suggest reaching out to her through NAMI Greater Houston, NAMIGreaterHouston.org, www.NAMIGreaterHouston.org. Either of you want to take a shot at that response?
I do know that there are several programs that talk about if the caller, excuse me, I said caller, if the person who's on the chat room, if they would Google, they'll be able to find mental health programs for different age groups, and they kind of like go from different aspects, like for the classroom perspective. If I can send that back to you, because I've done a lot of work with the school district and talking to principals to integrate mental health into HISD system to be able to do that. But there are programs that are developed, that are out there. He or she who asks the question would just have to Google it and they'll be able to find. And it kind of helps students to become peer counselors. It introduces that part as far as educating on mental health within the districts. A lot of times the school counselors are not able to actually, or may not be trained in the area of mental health. Because their responsibilities and what they've been given are tasked to do are to help with scheduling and things of that nature. So therefore, and some are able to, it just depends on, how the school is developed or how it's set up. So, but I know there's a very strong, for the lack of better terms, a very strong network within the school districts in order to be able to share information. And a lot of school counselors reach out beyond the school if they need help. I've seen that quite a bit, and principals and everyone else are now realizing how important it is to integrate mental health into the schools. So I can send that back to you at a later date, and you can just put it on whatever, some of the listing of places that I have, but I have done and looked at several curriculums.
Thank you so much. Thank you for your responses. We are just about out of time. It is clear from each one of our dialogues that we've had over the last 3 weeks. Not only are we acknowledge the level of tremendous expertise from the therapists that have helped us gain insight into the therapist's window or couch, if you will. Secondly, and so we thank you, Dr. Beal and Dr. Nero, for your responses and your comments today. Secondly, we know that we may not be able to get to all of your questions, but certainly we want to have you to reach out to us at NAMI, www.NAMIGreaterHouston.org, www.NAMIGreaterHouston.org. And then just before we have our last piece I don't know if we have enough time to run the commercial, Jessica, but let me just mention the resource guide. If we can pull that up for everyone. There are 3 aspects of the resource guide that I mentioned earlier, and there is help available. Persons within the spectrum, within these 3 spectrums. Number 1, emerging unwellness. Number 2, unwell. And 3, in crisis. And then on this same resource guide, which is on NAMI's help resource page, there's additional information about crisis hotlines that are accessible as well. And that's just coming down to page 2. So that you see the number there, 713-970-4483, 713-970-4483. 483. Please do us a favor and send this to as many people as you can. The more people that get word about this, about where the resources are and how they can access them, you never know when they're able to reach out and get the help that they need. So again, we are so appreciative for you joining us today, and we are grateful for our guests and our speakers and our presenters that have given us the time out of their very busy schedules and practices to come and join us. Thanks to the entire NAMI team for your tremendous support. Jessica McDaniel, Neil Sarahan, Aditi Chokti, and Asta Sharma. Thank you, Dr. Nero and Dr. Beal. Thank you so much to our audience. Please join us next week. Next week is the final week. We will have Diaspora Dialogue, Mental Health for Equity Dialogue 4. And we will be coming to you live from the Luke Church in Humboldt, Texas. And we will have two dynamic peer advocates that will speak to our issues in general in the mental health field. Thank you so much. Have a good evening.
All right, thank you. All right, bye-bye.
Bye, everybody.